Hi, everybody. My name is Suzanne. I am the third party manager here at SCRC. And today we will be talking about the process of finding an egg donor and a sperm donor. And here we have Dr. Chavkin, Diana Chavkin, with us, along with Lei Bai, the reproductive attorney. Next slide.
Hello, everyone. I'm Dr. Diana Chavkin. Thank you, Suzanne, and thank you, Lei, for being here with us today. I am a fertility doctor. I'm a reproductive endocrinology and fertility specialist. I focus on third-party reproduction, so this topic is particularly of interest to me. I love helping families, people create families from egg donors and sperm donors and third-party reproduction. So I think this is a really, really great topic. I also focus on reciprocal IVF and LGBTQ plus family building, as well as focusing on IVF protocol optimization, and stimulation protocols, as well as fertility preservation and recurrent pregnancy loss. I'm from New York originally. I've been in Los Angeles for about 10 years now. Prior to that, I lived primarily in New York. I got my bachelor's at Columbia, my medical degree at New York University, and then I did my obstetrics and gynecology residency training at the University of Pennsylvania, as well as my reproductive endocrinology and infertility fellowship. And so I'm very, very happy to be here with SCRC, where we have an amazing third-party program. This clinic is really wonderful. Our clinic has been around for about 25 years, so one of the longest, if not the longest running fertility practices in Los Angeles. And I'm just very proud to be here with such amazing staff, amazing physicians, and an amazing lab. So thank you. Happy to be with you today.
My name is Suzanne. I'm the third party manager here at SCRC. I've been doing this for a little bit over 14 years now. Love it. Like Dr. Chavkin, I love third party helping couples achieve, their ultimate goal of having their baby. I started from the bottom as an administrative assistant at an agency, went to different clinics. And I've been an egg donor myself, and I've helped many and thousands of couples achieve their goal.
Hi everyone, this is Lei. I'm an attorney in this area for around 9 years already. So I was originally born in China, and then I came here for my law school. I went to law school in UC Davis, and then I got my JD degree. And then my first job, I just got into this area for surrogacy, egg donation, and then I practiced in this area for around almost 4 years. And then I work at Deloitte as a legal consultant for some time. And then later I just decided to start my own firm. So I have been practicing for my own firm for around 5 years already. So we have helped with intended parents and also egg donors and also surrogates for over thousands of cases. So for now, I'm licensed in several states, including California, New York, Oregon, and Michigan. So thank you so much. And I will be happy to explain some about egg donation law today. Thank you.
Great. So SCRC, as I mentioned, we've been around for a very long time, proven track record. And I think that's super important to work with a clinic who not only knows what they're doing, but also has been around for a long time. It takes some time, I think, for clinics to kind of work around the kinks of third-party reproduction, quite honestly. There's a lot of moving parts, a lot of pieces to this, and there's a lot of details that really need to be paid attention to. And I think that really requires having a team and a clinic and a lab and an entire practice that has just been around for a very, very long time and knows how to do that. And that's what we have here at SCRC. Our lab is state of the art. Our embryology lab is really amazing and very well staffed. Lots of amazing embryologists who've really been doing this for a very long time. We have a laboratory here in Beverly Hills, as well as in Santa Barbara. These are kind of our different facilities you can see here in the pictures. We have on-site surgery centers, and we have our locations. We have satellite locations, office locations, as well in Pasadena and Ventura. And as I mentioned, Beverly Hills and Santa Barbara are where our laboratories are located. Next slide. So what sets our lab apart? So the premier laboratory and surgery center. So what's really great about our clinic here in Beverly Hills is that we have our clinic where we see our patients. We have our surgical center where we do our procedures and we perform surgeries as well as egg retrievals. And then we also have our laboratory here as well. And that's where we do our embryo, in conjunction, we do our embryo transfers. So we have experienced and certified lab directors. We have a very important double witnessing verification program, and this is really crucial. This is not actually a requirement, and so a lot of labs don't actually have this, and we think it's just so important for safety. As I mentioned, there's a lot of moving parts in third-party reproduction. There's a lot of moving parts in even just general IVF, and so it's really, really important and important to us, important for the physicians who have implemented this to have this special witnessing verification program that doesn't just rely on somebody kind of labeling something, but has a double witness program to make sure that things don't fall through the cracks, things don't get missed, and things don't get mislabeled. Super important to us. Vitrification. So our freezing method is flash freeze. Vitrification is a method in which embryos and eggs are placed in high levels of cryoprotectant and are frozen almost immediately. That diminishes the chance of ice crystals from forming. Ice crystals are in fact damaging to cells. And so to avoid that from happening, we do vitrification, which is state-of-the-art process. Blastocyst biopsy. So after an egg fertilizes and an embryo develops, a few days later, a blastocyst forms. And that's what we call the embryo stage at which we can biopsy the embryo. So our very technically skilled embryologists can take an embryo, take a few cells off of the blastocyst, take those cells, and then send them off for testing. We actually take the cells that are part of the trophectoderm, which is the cells that will eventually become the placenta, not the actual baby. So it's safe in that way. Those cells are then sent off for testing for PGTA, pre-implantation genetic testing for aneuploidy, to look to see if the chromosomes are normal, make sure that there are the appropriate set of chromosomes, as well as PGTM, so pre-implantation genetic testing for monogenic disorders. So those things are things like Tay-Sachs, sickle cell, cystic fibrosis. So essentially, you know, we could be potentially carriers for hundreds of disorders, autosomal recessive disorders, but if an egg source and a sperm source are both carriers for that disorder, then there's a chance that the embryo can be affected with that disorder. And so we have special techniques where we can do testing for that particular disorder, and that's what PGTM is. Of course, we can do sex selection because when we get the chromosomes, we'll find out if the gender of the embryo is a male or female. We have the EmbryoScope, which is really wonderful. So the EmbryoScope allows us to monitor the development of the embryo in a closed incubation system. So meaning we don't have to interrupt the incubator, interrupt the embryos to check on them. We allow them to grow in this closed system, and we actually take videos. So we can take videos of these embryos develop. It's time-lapse videos. So it's really wonderful, and it helps us and our embryologists choose which are the best quality embryos to then transfer. So really important and amazing technology. Next slide.
So today's discussion will speak about building your family with an egg donor and a sperm donor, or process of finding an egg donor or sperm donor, beginning till the end from matching to delivery, along with the timelines, and then meeting our team, and then we'll have at the end question and answers for you guys. Next slide.
Great. So, so donors. So what are some of the things to think about? So for same-sex male couples, they'll need an egg source. So usually an egg donor and a gestational carrier, someone to carry the pregnancy. And one or both partners may provide sperm for fertilization. So we can create embryos potentially from one egg donor, fertilized with one sperm source, and then potentially have the eggs with another source, or we can just use one sperm source depending on the preferences. Same-sex female couples can use donor sperm, and one partner can carry the pregnancy, or reciprocal IVF is actually often done. And that's where one female partner provides the eggs for the embryo creation, and then the other one carries. And I've had people actually do reciprocal IVF twice. So where one is the egg source and the other is the carrier, and then vice versa. So that there's participation on all levels, if that's desired. Heterosexual couples can pursue third-party services as well due to medical, genetic, or personal factors. And of course, their options as well are egg donor, sperm donor, a donor embryo, where we can have actually an embryo that's donated, but from somebody else to another person, or surrogacy or gestational carrier programs. Next slide. So pursuing motherhood independently. So if a woman wants to conceive using a sperm donor, she of course can do that with our help, and she can do that with IVF or without IVF. So we can use insemination or we can use in vitro fertilization. She can also use donor egg if that's appropriate, or donor embryo options can also be considered and often discussed depending on the particular situation, her age, and her ovarian reserve. Pursuing fatherhood independently, of course, that would require an egg source and a gestational carrier. And they can use their own sperm. They can also use donor sperm depending on the specific circumstances. And so, right, so medical eligibility, donor, gestational carrier screening, legal requirements, and ethical standards are carefully reviewed for each pathway. And of course, they're extensively discussed with your care team. Next slide.
So our third-party team, my third-party team, will be the coordinators of your journey. In order to look for your donor, sperm donor, egg donor. We'll start from medical screening, reviewing medical records, and making sure that it is seamless and we're providing the best compassionate care for you. Your process is discreet and it's seamless. We want to make sure that from the beginning till the end that you're understanding the process, and if you have any questions during the process, we're here to help you and guide you. We want to maintain a clear, consistent update. So we're updating you all the time regarding your journey. If you have any questions, just give us a call. My team is here. So yeah, we're here to help you with the process and the journey in regards to finding an egg donor and a sperm donor. Next slide.
So choosing a donor source. So where do donors come from? So there are banks. So I would say that most of my patients who use sperm donors will use sperm donors from a sperm bank. There are a number of different banks we work with. It's actually quite easier than I think people at first anticipate it will be to choose a sperm donor because the sperm is frozen. There's tons of information, although a lot of it is anonymous, and we'll talk about that in a moment. Although many of the sperm banks are from anonymous individuals, there's actually a lot of information about these individuals in terms of their family history, their likes and their dislikes, and that's all available on these websites. And in fact, it's very easy to choose a sperm sample from these websites and from these programs, from these banks, and it's usually a very seamless process. There are also egg banks. So in the same way that sperm can be frozen and stored, eggs can be frozen and stored as well. And we often will work with many egg banks to facilitate that. There are agency-based donors. So if somebody wants to work with a sort of a live person, so an egg donor who is going to undergo stimulation, and potentially all of those eggs go towards that intended parent, that is an option as well. So donors can be known donors. They can also be anonymous versus open identity release donors. So known donors, right? So if you have a friend or a family member who's interested in donating their eggs or their sperm, we can definitely facilitate that. It does require a little bit more legwork and some more logistics because if the eggs and the sperm are sort of frozen in advance and it's sort of done and it's all said and all we have to do is have you purchase the eggs or the sperm, all of the legwork has already been done, but there's a lot of legwork to kind of get that process going. So, the individuals have to have a history and a physical. They need to meet with the physician. They need to be examined. Tests need to be done to make sure there's no infectious disease and make sure psychologically they are approved, and all of the legal contracts need to be done as well. We do this and it's definitely possible, but it does just, it does take a little bit more legwork. Anonymous is probably the more common one, although I think people are starting to do more somewhat open identity donors, and there's also identity release, right, where potentially someone might be open to being contacted in the future, and that's kind of more of a common thing that's being done now. Fresh or frozen gametes, so that's always an interesting conversation. I would say with sperm, it's pretty clear whether you use fresh or frozen sperm. It really does not matter. Sperm they're kind of hardy. There's a lot of them when they get frozen, and so this is, I think, probably the reason why historically we've been using frozen sperm for a very long time, and we don't see in general there to be any lower outcomes when using frozen sperm compared to fresh. Now, eggs is a little bit different. So, the issue with eggs is that each egg it's one cell, but it's actually a large cell, right? So when we're freezing sperm, we're potentially freezing millions and millions of sperm. When we're freezing eggs, right, we're freezing maybe 6 eggs, 12 eggs, right? And each egg took a lot of work to get. And each egg, again, it's one cell and it's large and it has a high water content. And the concern is that when you're freezing eggs, you're essentially causing potential stress to that egg. Now, we talked about vitrification a little bit ago, and vitrification is the tried and true method for egg freezing, and it is the method by which most places will freeze eggs, and it's how we freeze eggs, and it's how most egg banks freeze eggs. However, still freezing the eggs does impart somewhat more stress to that egg. And so I think, in general, different physicians have different opinions. My opinion is that in general, fresh eggs probably do better than frozen. But to what degree, it's hard to say. And is it always worth it to do fresh versus frozen? I mean, that's always a conversation to have with physicians, with your particular physician. But again, we definitely do work with fresh eggs and fresh sperm for that matter, obviously, and then as well as fresh and frozen eggs to create embryos. And how do I choose between fresh or frozen sperm or eggs? Again, this is a conversation you have with the physician. Sperm, very, very common to use. Frozen. Eggs, I would say, we'll use frozen and fresh depending on the situation. And the one thing also to keep in mind about the eggs, whether you're doing fresh or frozen, is that with frozen eggs, you're essentially buying a particular lot. You're buying a specific number. So you're paying for, let's say, 6 frozen eggs or 12 frozen eggs, however many eggs you're paying for. With a fresh cycle of eggs, meaning you're having a specific egg donor who's going through stimulation, you then basically own all of the eggs that particular egg donor may make. Whether that egg donor makes 10 eggs or 20 eggs or 25 eggs, right? You own all of those eggs. Of course, it's a bit of a gamble because there's no guarantee really in how many eggs that particular egg donor will produce, but good chance she'll produce a good number if she's an approved egg donor, which of course she would be going through our program. But essentially, usually when you're using fresh eggs, you end up with more eggs when you do a fresh stimulation and you get fresh eggs. So that's one thing to think about. Next slide.
So locating your egg donor, we will send you a list of recommended agencies, sperm banks, egg banks, agencies, donor agencies, and sperm agencies. So what we've worked with before. Most agencies we work with also send us the medical records for your donor, depending on if they've been an egg donor before for fresh donors. We review that with your doctor to make sure that she is a suitable candidate for egg donation again. So we review that along with the psychological. We want to make sure that genetically the donor and sperm donor are genetically compatible with either the sperm source or the donor source. Next slide. So this is where you're developing your criteria for your specific egg donor and or sperm donor. We like to ask you physical traits, hair color, eye color, what else? Height and weight, genetic screening results. So sperm donors, sperm banks, they tell you what they've been tested for. So you can actually make sure that you're in there genetically. You can say you don't want anybody genetically positive for these tests. So those are some of the things that you want to think about. Open along with versus anonymous donor preferences for fresh donors. Most of the time it is anonymous egg donors, unless in your legal contract it does state, and Lei will be able to talk about that a little bit more. For sperm donors, most of the time, like Dr. Chavkin says, it is anonymous most of the time. We also want to think about donor availability for fresh donors, location, and timing. So for fresh donors, it does take a little bit longer. So those are the pros and cons about using a fresh donor and a fresh donor and a frozen eggs. Frozen, it's quicker. You'll choose an egg donor on the database. You'll choose how many eggs you'll want, and then they'll ship the eggs to us. For fresh, we do have to do medical screening, legals, and then the egg retrieval. So that usually could take about 2 to 3 months until we retrieve. So you do want to think about some of the personality traits that you're looking for, values and personal interests at each donor, and you'll be able to see that. And now you'll also be able to see videos of your egg donor, sperm donor, so you'll be able to understand who they really are. Next slide.
Anonymous donor and known donors. So this is like 2 different types of egg donation contract and also for sperm donation contract. So the basic difference for like anonymous and known donor is just like if you know the other person's like legal name. So if it's anonymous, usually just means like you don't even know that the donor like personally. Usually it will be like a match through agency, and it just means like under the legal contract we will structure in a way like we will define the donor or the IPs by like initials by the donor's ID, and we won't say like the full legal name of the donor and also the full legal name of the intended parents, which just means from the contract itself, like we don't know the other party's full legal name. And we're talking about this because we have like intended parents and also donor, like even till legal stage that when we are asking, do you know if it's like anonymous donor or like sperm or like known donor, they don't really know. They were saying, what is anonymous? What is like known? I have her ID, like ID number. I have like another, like kind of like a fake name. Is that like anonymous or is that known? If you don't even know like the type, like the nature of the donation, it will really affect the contract, because the contract will structure, we put it like if it's known or anonymous in the contract. So be better to know it, before legal. Next slide, please. So for the pro cons of the anonymous and known donors, there's not really like which way is better. It really depends on like how you know the donor, and also sometimes it depending on like your preference. Like even if, maybe we know the donor, like you don't know the donor, but even if it's through agency, most times, of course, it will be like anonymous donor, but there's a few situations, or maybe under a few like medical reasons, or maybe from the donor's nationality, it will still be like a known donation. But no matter it's like known, anonymous, or like semi-open, like sometimes it does not matter. We will always make our legal contract to say the intended parents will have the full legal rights over like the donated eggs, sperms, and embryos, and also have full legal rights, will be the legal parents of the child, born from the eggs. So it's like same for this parentage part. Next slide, please. And there's some like legal tips we want every single intended parents to know before you review the donor profile. The first one is, of course, know the nature, because we do have it happen, like if the intended parents give us like a wrong information, actually if it's anonymous donation, if the intended parents thought it's known donation, when we draft the contract, we say it's known, then it just make the thing really complicated if actually it's anonymous donation, because you saw the donor's name already, in the contract, if you don't know the nature at all. So that's the first thing. And second thing, of course, find a doctor from like, SCRC, like licensed medical clinic, and also from like a legal country, like sometimes maybe some overseas intended parents, just do it, legally, find a better IVF clinic to do it. And then the third part is about the legal parents. So like who will be the legal parents? It's really something you should plan like in advance. We have like intended parents, maybe they're same-sex marriage, if they're like same-sex intended parents, especially if they are like from some other countries, let's say like China, it's illegal for same-sex marriage. And if you want to find an egg donor with your partner, you have to think about it. Like, will the contracts be also legally recognized for me to get travel documents? This is something you should think about. Yeah, also another thing is if you're not like legally married at this point, then think about it carefully. Do you really want to sign an egg donation contract, sperm donation contract with your partner, or you want to just sign it with yourself? Because it really matters of like who will be the parents of the child born from the egg donation. If you don't plan like earlier, then it will be really like messy and complicated. And another thing that's about the like how to find lawyers. So when we have clients asking for legal consultation, they don't even know like which state of attorneys I shall pick, because sometimes the intended parents, they are international, or they are just like from, let's say, like Oregon, and then donor is maybe also international. The donor is from like New Jersey, in the clinic like it's in California. Then which state of attorneys I shall pick? I will say like any like state that's related to this cycle. It could be a state of law that could be applied. For example, California is very friendly, then we will always like pick California law, and then you could find an attorney from licensed in California. And the last thing is about future contact. It's always because like it's especially for like known donation, like if you know each other, and then of course our clients, they will care, hey, I want to have future contact, and maybe I also want to keep it open for my child to have some future contact with the donor. And also if it's anonymous donation, most of the times they don't want to have future contact. So better think about it in advance, what kind of like contact I want to have. Next slide. Thank you.
So matching with your donor and financial clearance. So once you've located your donor and your sperm donor and/or your agency will send us medical records, psychological screening, and genetic screening, so that we make sure that your doctor and myself will review those records to approve your donor. Once she or he have been approved, we'll get SCRC's financial team will reach out to contact you in regards to costs and associated with your cycle. Next slide. Once you've been matched and everything is good to go with medical records, your agency will send us the match sheets for your donor. Donor profile, summarizing their medical history, genetic history, and information demographics so that we can reach out to your egg donor to go ahead and come in for cycle. Again, our team will manage beginning till the end until egg retrieval. Dr. Chavkin, all the doctors will be in contact in regards to next steps. Every appointment that your donor does have will be reaching out and giving you all the updates. Next slide.
So medical screening for egg donors. So once you choose your egg donor will meet with your doctors for a series of tests, including blood work, urine tests, cultures, past and genetic testing. And also, of course, need to sign the necessary consent forms. So, we'll, as the physicians, we'll meet with the egg donor. I treat every egg donor as if they're a new patient. So I take a very thorough history, speak with them about the process, do a physical exam, and do a very kind of just a thorough evaluation to make sure that this is an appropriate person to undergo stimulation to produce eggs for you. Next slide. Screening for sperm donors. So again, if this is a live sperm donor, so not from a sperm bank, but a person that we are going to screen and choose as somebody who's going to produce sperm to make embryos for you. Again, I would treat this person as if they were my new patient, meaning I would meet with them, have a very thorough face-to-face history, physical exam, and the doctor will do a series of tests, right? So like I mentioned, medical and family history review, the appropriate infectious disease testing, genetic carrier screening, so to see if the sperm source is a carrier for specific autosomal recessive disorders, semen analysis and quality assessment, as well as psychological evaluation. And of course, he'll need to sign the necessary consent forms. Next slide. Medical clearance. So once your egg or sperm donor is medically cleared, you'll be instructed to work on your legal contracts. Next slide.
Legal contract. So legal contract always start at the timing after medical clearance. Our clients are always asking, like what is a step after the consultation? The consultation, I will always tell my intern parents after medical clearance, so notify the legal attorneys to start the contract. So the whole process usually it will just take like 1 to 2 weeks, but really depending on the intern parents and also the donor. Usually the process will just be like we represent the intern parents, and then the donor usually he or she will also have his or her own attorney. And then we draft the contract for our intern parents, have it to review and approval by the intern parents. Usually this process will just take maybe like 3 days, and then we will send our contract to the donor's attorney, and then we discuss till it's finalized. And then after it's finalized, usually like for egg donation contract, sperm donation contract, and also sometimes we'll have embryo donation contract. It does not really have to be notarized by law. But for some situation, like if it's maybe like between partners, we will require the contract to be notarized. Next slide, please. And then after the contract is like fully signed by both intern parents and the donor, as the attorneys, we will send our legal clearance letter to the IVF clinic to notify the IVF doctor, like SCRC, hey, the contract is fully done, please start and prepare the cycle for the donor. So don't be concerned, we will always notify the doctor. And next slide, please. So this is kind of like some take-home tips for our intern parents, and I do want to mention like the first thing is about the donation contract. We do see like sometimes the intern parents or maybe the clients, they have like sperm donation done already, egg donation done already, but they don't have a legal contract done before. When they were asking us, they already have, it's done, but it's not your egg, it's not your sperm. So always do the contract, before the donation is done. So you can make sure once like the egg being retrieved, the donor, the sperm being collected, then by legal, it's yours. So this is really important. If you don't have like a valid sperm donation, egg donation contract done before, you're really putting yourself under legal risks. Like you pay the money already, but you don't have it. So the second thing is really like related. Why we need to have like a donation contract well written? It's just because you want to be the parents, right? If you want to be the parents, then you should have a donation contract, and then which is also always required by the doctors before like proceeding with like a surrogacy contract, and also will be necessary for the attorneys doing the surrogacy part, and also will be necessary for the court to consider, do you really have the full ownership of the eggs, the embryos? So that's very important. And yeah, next slide, please.
Injectable medication. So the SCRC third-party team will send you the cycle calendar and order the medication. So the cycle calendar essentially will have written specific dates of potentially birth control pills. So sometimes we'll use birth control pills prior to beginning the injections for the stimulation process. And so those specific dates will be given. We'll also have specific dates for when to stop birth control pills and when to begin the injection. So we give dates for when we will begin the injections, when we think the monitoring visits during the stimulation period will occur. So while we have the woman, the egg donor, take subcutaneous injections to stimulate her egg, she'll take those injections for a period of around 10 to 12 days. During that time period, she'll come in for ultrasound visits and blood work to make sure that she's responding appropriately. Those results will then be reviewed by the physician, and the physician will decide if those doses need to be adjusted, because we're always sort of tweaking things to get the best response possible. We'll then have a target date for when the egg retrieval will be. And so this is kind of all in the advanced calendar, but it's a little bit tentative because we don't always know exactly when the physician will want to bring the egg donor in for those monitoring visits, or when the actual retrieval will be. Sometimes it's a few days earlier, sometimes it's a few days later. But the predicted calendar will be provided to you, and your third-party team will also order the medications that the physician will prescribe. Once everything is in place, your egg donor will begin the medications in preparation for retrieving the eggs. Next slide. So here is the egg retrieval timeline. So this is a busy slide, but essentially, I mean, the bottom line of this slide is that we do ultrasounds prior to starting the injections. We then have the egg donor take injections to stimulate the eggs. And while she's taking those injections, she's coming in for ultrasounds to make sure things are developing appropriately. And then we get her to the point of the egg retrieval procedure once we see a nice number of mature eggs developing. And so that's essentially what this slide says. So the baseline ultrasound, and at that ultrasound, we'll see what are called follicles. Follicles are the pockets of fluid on the ovary that contain the microscopic eggs. That gives us some sense of what might develop over time during the stimulation. At that ultrasound, we also want to make sure that there are no large cysts or big pockets of fluid that might obscure the development of the follicle. So that's another important part of the ultrasound at baseline. And then the ovarian stimulation. So that's, again, where she's taking injections to stimulate her ovaries under the direction of the physician. And these are the monitoring visits that she comes in for during the stimulation period are usually very quick visits. She's usually in and out, probably less than 20 minutes for these visits. And then once we see a nice number of large follicles and we see that the estrogen level looks appropriate, we'll have her take her trigger shot. That's a very important injection that's taken 36 hours before the egg retrieval procedure. Then the egg retrieval procedure is done. That's done under anesthesia while the egg donor is asleep. We'll place an ultrasound probe in her vagina attached to a needle. We'll take the fluid out of the follicles, give the fluid to the embryologist. The embryologist will then have those eggs. They'll fertilize the eggs in the lab, and the embryos will then be cultured in the lab. It's about 2 weeks of treatment. We say 10 to 12 days of stimulation, and then the retrieval potentially is on the 12th to 14th day. Blood work and ultrasound, about 5 to 6, maybe less sometimes. And the procedure for the egg retrieval procedure under anesthesia, it's about 20 minutes. Next slide. So here is kind of a picture. So as I mentioned at baseline, what we're looking at are follicles. So here's a nice little picture of an ovary, and you can sort of see this honeycomb appearance of these follicles. This is what we could see on ultrasound. So on ultrasound, we could see the follicles. Inside the follicles that we see on ultrasound are microscopic eggs. Now, we cannot see eggs, and I always tell people I really can't guarantee that an egg is developing or what's really in there. We assume that there is an egg in there if it's developing and growing appropriately, but really what we can see are the follicles. And then at the end, when we do the egg retrieval, then we remove the fluid, and then the embryologist can actually look at the eggs under the microscope. But what we see on ultrasound are these follicles. And you can see on day 1 at baseline, you see a number of the follicles. They're all kind of small, kind of just waiting there, waiting to get recruited. And then as the woman is taking her injections to stimulate the follicles and stimulate the eggs, the honeycomb grows bigger and bigger. And you can see these follicles getting larger and larger. And that's usually what you see on day 10 to 14. When we see a nice number of these big mature follicles, we say that she's ready for her trigger shot. And then on the day of the egg retrieval, so this little, I'm going to direct your attention to this cartoon over here. So you can see is an ultrasound probe being placed in the vagina attached to a needle. The needle goes through the vaginal wall. Here, it looks like the ovary is kind of small, but that's actually a baseline. What happens actually on the day of the egg retrieval is that ovary takes up a lot of space, and that ovary is actually just resting right up against the vaginal wall. So it's actually very, very simple to see on ultrasound the needle going right through the vaginal wall and going right into the follicles and taking up the fluid. And that's what you can see sort of at the bottom picture here on retrieval day. You can see this arrow pointing to a needle going right into a follicle, and we just kind of suck out the fluid under visualization and then go take one at a time, remove the fluid, and give it to our embryologist. Next slide. So embryo transfer. Well, before we get to the embryo transfer, what will happen is once those eggs are retrieved in the lab, we'll take the eggs, obviously, and the embryologist will take the sperm, fertilize each egg with sperm. We can either do intracytoplasmic sperm injection, where we inject sperm into each egg to induce fertilization, or we can do what's called conventional insemination, where the egg is placed in a dish and sperm kind of float around and finds its way in. But either way, embryos are then formed. The embryos usually take about 5 to 7 days to develop. And then the embryos can then be biopsied and frozen. The biopsy samples I had mentioned before, those biopsy samples are then sent off for testing, and then we find out about 2 weeks later which embryos are chromosomally normal, what the gender is, and then of course we can let you know. And then once you're ready for the embryo transfer, we can proceed. So we can either proceed with an embryo transfer into you or into your surrogate, and the embryos are of course monitored in our lab. And if you are pursuing pregnancy independently, you can use IVF, as we mentioned, or you can use intrauterine insemination. Next slide. The embryoscope technology. So this is a really cool picture, time-lapse video, as I had mentioned. Again, this is the closed incubator system that allows us to video the embryos as they develop. And, you know, what's really nice about this is, you know, back in the day, we used to kind of look at the embryos at different days and different stages and say, okay, this is, you know, what this embryo looks like. But what's really nice about this is we can actually see how quickly embryos developed and how symmetrically they develop. Because sometimes at the end of the day, you know, we may have a nice number of embryos, and we may have 2 or 3 embryos that all look like they're good quality. And the question is, well, which is the best quality embryo? So what our embryologists often will do is they'll go back to this video of the specific embryo and say, okay, you know, at the end, all these maybe 3 embryos all looked identical, but actually there's one that definitely stood out in terms of how nicely and symmetrically it divided and developed. And we only know that because of the data we get from the embryoscope. Next slide. Confirmation of pregnancy. So if you, right, or your surrogate, right, so we'll have blood work. So we'll get a blood test to confirm the pregnancy, and then we'll do 3 ultrasounds. So we'll do an ultrasound usually at 6, 8, and 10 weeks. And then we send you off to you or your gestational carrier to your general OBGYN. Next slide. And then this is where the famous graduation visit. So once a number of ultrasounds are done and the blood work looks good, you go off into the real world and to see your OB, and your OB will eventually deliver you. And we wait to hear good news. Next slide. So here is the timeline. We kind of, it's again a busy slide, but kind of step 1, locating your donor, consulting with an attorney, match meeting with the donor. That can take some time. Of course, financial clearance needs to be performed. Match sheets need to be created. There's medical screening. And we talked about the details of that kind of thorough screening and meetings with the physician. And there's also step 4 is if you're going to use a surrogate, there'd be screening of a surrogate and medical clearance as well as legal clearance. There's also at the bottom, you see the injectable medications that we talked about. The embryos are then created and embryo transfer is performed again to you or the surrogate, and then confirmation of pregnancy and graduation at 10 to 12 weeks of pregnancy. Next slide. Here are our physicians at SCRC. So over 20,000 babies. That's a lot of babies. Very, very, really, really great to be a part of this team. So we have Dr. Mark Suri, who sees patients in Beverly Hills and Santa Barbara. Dr. Hal Danzer sees patients in Beverly Hills. Dr. Carolyn Alexander sees patients in Beverly Hills. Dr. Susan Maxwell sees patients in Santa Barbara and Ventura. And I see patients in Beverly Hills as well as Pasadena. And all of us, any of us would be happy to meet with you. We do in-person consultations as well as virtual telehealth consultations. And yeah, thank you for listening in today. Next slide. So yeah, please ask us your questions. Please mention the webinar promo code. We're here to help. I think a lot of this can be quite overwhelming. I think if you took away 1 or 2 points from this, that's great. I always tell people, especially at my initial consultations, try not to feel like you have to remember everything. Just kind of hear what you can, absorb what you can. But we are really here to answer questions, honestly, over and over again. I know Suzanne does that a lot. So answering questions and more than happy to do that. So thank you again for tuning in today. And thank you, Suzanne and Lei, for being here today. Next slide. Or if that's it, I guess just ask us your questions. Thank you. Somebody asked to be emailed a link to the deck. So that's for Leah, I think, listening in, if that can be done. Is it best to go to the location near to where you live, work, or are there more resources at Beverly Hills location? Really good question. So in general, kind of both are true. So it really is okay to go where you live and work. That is really the best option, because there are a lot of visits that you are going to come in for in terms of, let's say you're doing monitoring, let's say you're doing a stimulation, you'll come in for regular monitoring visits. And our very same sonographers who do our ultrasounds for our monitoring visits are in our Beverly Hills location. They're the exact same ones who are in Pasadena. So it really does not matter kind of where you go for those visits. A lot of visits end up being blood work. There's a lot of things we do by telehealth. So it really does not matter. I think what's really important though to understand is that we only have our laboratory and surgery center at either Beverly Hills or Santa Barbara. And so, I actually do see a lot of patients in Pasadena. I have a lot of Pasadena patients, and it's great. And they get, again, the same care that they would get in Beverly Hills. But when it's time for the egg retrieval or embryo transfer or any surgery, they have to come to Beverly Hills. So, go where you live, go where you work, but just be prepared that for the specific procedures that need our lab and our surgery center, that would have to be in Beverly Hills. Any other questions? Okay, looks like maybe not, but feel free to send them over. I got to thank you. Good, you're welcome.